Good morning, everyone. My only regret, as I was saying, is that if only this were a window out to the Charles River. It is one gorgeous day, and I appreciate your willingness to come in on an absolutely beautiful day, and one we haven't had before on a weekend, so I hope you enjoy your afternoon for sure. So it's my great pleasure to welcome you to our second annual Hubie Jones Lecture in Urban Health. And it's lovely to have our alumni, our students. We have faculty here, administrative staff, our fellow colleagues in social work and in related fields, and our family members and our friends. I'm delighted that you chose to attend today, and I think, as you know, this is an endowed lecture named after Hubie Jones, who will speak shortly. And Hubie, of course, is widely admired for his incredibly skillful mobilization of people from all walks of life to support the communities that desperately need their help, especially the youth and the families in those communities. Hubie's most recent efforts are evident in his ongoing work in Higher Ground, which is loosely modeled on the Harlem Children's Zone in New York City. And this major initiative, we certainly hope, will serve Boston's inner city children, families, and the community. His work to develop the internationally traveled Boston Children's Chorus, City Year, and many, many other Boston-based initiatives is unparalleled among us. This is a remarkable experience. And in that spirit, we will be welcoming our speaker this morning, Dr. Donald Berwick, who will be introduced shortly by my colleague, Associate Dean Harold Cox. But first, let's have a few words from Hubie. I will be moderating the Q&A after the talk, and we will ask you to speak into microphones, but I'll remind you, anyone needing services this afternoon in the restrooms are out this door and around the hallway. Thank you for coming.
Great, thank you. Thank you very much, Gail. Good morning to you. Good morning.
Good morning.
You are alive and well. It is my pleasure to welcome you to the third annual lecture in urban health. For me, it is absolutely delicious to have this lecture series that recognizes my service to the Boston University School of Social Work and the Boston community. Thank you for being here this morning. I thank Dr. Donald Berwick for taking on this assignment, particularly when there are other more important claims on his time right now. We really appreciate that. On this day, April 12th, in 1945, President Franklin Delano Roosevelt died. I can remember as an 11-year-old boy living in the South Bronx where I was when the news of his death came. Based on the reactions of my parents, I knew a great loss had occurred. President Roosevelt moved us toward being a society that is more committed to public purpose than private interest. Today, we still struggle to embrace a public purpose posture. Last Thursday evening, I attended a stellar forum at Harvard University celebrating the 40th anniversary of the Children's Defense Fund and the extraordinary work of Marian Wright Edelman, its founder and president. Speaker after speaker asserted that the keys to achieving excellent educational outcomes for children, poor children, and children of color in this country are for them to have access to effective early childhood development resources and excellent pre-kindergarten education. They also asserted that excellent prenatal health care for mothers and access to excellent primary care for children from birth on are critical for educational success. So last Thursday, I got teed up for Dr. Berwick's lecture this morning. He is a preeminent expert on health policy and practices. If you need to be reminded about how broken our political system is in Washington, D.C., just think about the fact that President Obama wanted to appoint Dr. Berwick to be the permanent administrator of the Centers for Medicare and Medicaid Services, but was blocked by a very partisan politics from doing so. This was a travesty and a great loss for our country. Nevertheless, President Obama appointed him to be the interim administrator of the agency, and during a very short tenure, he made excellent progress, which we are all grateful for. So we thank you for being here this morning. We thank you for your service to your country. We thank you for your service to humanity. And we are very honored to have you as our lecturer. We look forward to hearing what you have to say. I thank all of you for being here and being at this lecture and for keeping it going. Hopefully it'll last long after I'm gone from this earth. I thank you for being here.
Good morning. I'm Harold Cox. I'm the associate dean at one of the associate deans at the Public Health School, but I want you to know that I have social work roots also. I was trained as a social worker, and I also work with Luz Lopez and with Betty Ruth with our dual degree program in social work and public health. So it is my honor to introduce our speaker to you. So as I was thinking about this, there are a bunch of things that I think that I could say about Dr. Berwick. I guess first I could probably say something about the fact that he got trained at Harvard, is a pediatrician, and had as one of his first jobs being the vice president at the Harvard Community Health Plan as the first vice president of quality of care measurements. But I'm not going to talk about that. I guess I could also say that Dr. Berwick in the late 80s formed IHI, which is the Institute for Healthcare Improvements, which is an organization that has the sole purpose of redesigning the healthcare world. And at one time, the vision statement of IHI said that they wanted to make certain that there were no more needless deaths, there were no needless pain or suffering, no helplessness in those served or serving, no unwanted waiting, no waste, and no one left out. But I'm not going to talk about that either. And I guess I could talk to you about his interesting, and I'm certain that he would probably say challenging, appointment as the director of CMS. And I could probably tell you that CMS, which is the Centers for Medicare and Medicaid Services, is one of the largest services in the country, has a budget in 2011 of over $750 billion with a B dollars, has 4,500 employees, and that the appointment by President Obama was a very important one of bringing someone on board to help rethink the system. But it was controversial because there were those who thought that he might make a change. There were those who thought that this was the wrong person, but at the same time, there were those who were supporters as well. And one of those supporters said of his appointment, "From my perspective, putting someone in charge of Medicare and Medicaid who has saved countless lives and revolutionized the quality of American healthcare makes a lot of difference." But I'm not going to talk about that either. What I am going to, however, talk about is how I know Dr. Berwick. I actually just met him for the first time this morning, but I've really known him for a very long time. I used to work for the city of Cambridge for the Cambridge Health Alliance, which is the organization that manages the health department and runs a number of hospitals in the Cambridge area. At the time that I was there, Dr. Berwick and his team came to Cambridge to assist us in thinking about efficiencies and how to improve the services that we were delivering to the people in our hospital. And whenever Dr. Berwick was any place close by, there was a hush that went over the room, over the place. And people would say, you know, Don Berwick is here. And other people would say, what did he have to say? And then I had the opportunity to go to several of the IHI conferences down in Florida and to also watch Dr. Berwick in action and to hear, to watch him walk by and in clusters and people would kind of, gather around him and then they would say, Don Berwick is here, and other people would say, and what did he have to say? What I learned was that when Don Berwick speaks, people listen. And it's a very important thing to happen. So it's important then for us to have Dr. Berwick here with us today for the Hubie Jones Lecture, because Hubie is someone who has been an innovator, a leader, a visionary, someone who has been willing to say, let's make a difference and let's improve things. And Don Berwick, in the same manner, is a leader, a visionary, an innovator, and willing to say, let's do it differently. So today, I am very proud to say that Don Berwick is here, and I am looking forward to what he has to say. Please welcome Don Berwick.
Thank you. Thank you so much, Dean Cox and Dean Jones and Dean Steckity and all of you for the chance to join you this morning. Those words were very generous, but let me tell you how humbled and privileged I feel to speak in Hubie's name. For decades, I have admired this man as one of the great examples of leadership for the common good and for social justice. And the entire community, not just in Boston, but in the nation, and I think even worldwide, is indebted to you, Hubie, for your leadership. And I must say to your amazing life partner, who's been an example of courage as well for my entire career. I think I want to start with a metaphor, then I won't talk about it much anymore, but I couldn't resist throwing these slides in. You'll see why. This is a bridge in Honduras. It's the Choluteca River Bridge. It's near Tegucigalpa, the capital city. And it was built, as you see, in 1938. It was built by a famous bridge company, the American Bridge Company. They built the Bronx Whitestone Bridge. They build the best bridges, which is important in Honduras. They wanted a good bridge because the weather stinks and the bridges are subjected to lots of stress. And indeed, the Choluteca River Bridge was stressed to the maximum in its key test in 1995 when Hurricane Mitch hit Honduras head on. It was a killer hurricane, killed people. It took down about 150 bridges, I'm told, but not the Choluteca River Bridge. It stood miraculously, just as built, strong, durable, just one problem, which was when the river moved. So if you go to Honduras today, you will find a wonderful bridge in the wrong place. So this is American healthcare. Not exactly. In my remarks, you're going to hear how important it is that the first bridge exists. It crosses an important river, the river of need for acute care and miracles when we need miracles when we're very ill. But the other river is the one you know here as well as anyone does that is uncrossed. It's the one about chronic illness and the needs for care and caring through our lifespan, not episodes but journeys, and the river of prevention, and we'll be talking about that. One of my very favorite quotes for some reason comes from Walt Whitman, who said, do I contradict myself? Very well then, I contradict myself. I am large, I contain multitudes. And some lives do contain multitudes, and I'm going to talk about one of them today. It's the life of a patient of mine. I have written about him before, and you may have read, but its story is so profound and so meaningful to me, especially in Hubie's presence, that I want to tell this story again. I was on duty. I was the officer of the day, the pediatrician of the day at the Harvard Community Health Plan, where my practice was in the old Kenmore Square Center, not far from here. And suddenly, Madeline, who was my nurse practitioner, she ran up to me. She said, "You got to get into room 4 right now. That kid is in pain." He was in pain. Room 4 held a black teenager lying on the exam table, and he was writhing. He was sweating. He was swearing. He was screaming in agony. He had torturing back pain. This was Isaiah, I'll call him. It's not his real name. And though I didn't know it at the time, he was to become a part of my life for the next 15 years. And he will be part of my psyche for as long as I live. I misdiagnosed Isaiah that afternoon. I got the diagnosis wrong. I thought he'd wrenched his back, but I did take some blood tests, and I sent him home, and I went home. And then the phone rang in the middle of the night from the laboratory. It wasn't a back sprain. Isaiah had acute lymphoblastic leukemia. I didn't have his phone number. I didn't have his address, but the police helped us track him down that night. That kind of leukemia in a black teenager is pretty much a death sentence. The prognosis is awful. In a white 5-year-old, it's almost always cured, but not in a black teenager. But we pulled out all the stops for Isaiah. He had multiple admissions to several of Boston's major teaching hospitals. He did go into remission. And then 3 years later, as we knew he would, he relapsed. And we knew he would die. But we decided to try. We offered him a bone marrow transplant, which we thought was the only shot at cure. I remember driving to his apartment late one afternoon on the second floor of a ramshackle 3-decker in Roxbury. There was a weed-clogged vacant lot on each side of the building. And there I met Isaiah and his graceful, quiet mother at their kitchen table. It was covered with a plastic red checkered tablecloth, I recall. And I told them the stakes. Without a transplant, he would almost certainly die within the year. With a transplant, he might well die sooner. Transplants are very dangerous, and we didn't know if it would work. But he would have a chance. He'd have a small chance at cure. They didn't hesitate a second. Isaiah's brother turned out to be a tissue match for him, and so he was transplanted later that month. He had a very rough time. He developed diabetes, pneumonia several times. He developed very severe asthma, and incredibly, he almost died one night during his treatment, and he wasn't from leukemia. He almost died from medication error. After weeks in the hospital, months of tightrope care in the outpatient department, he pulled through, and he lived. His leukemia was cured. It never came back. We became quite close, Isaiah and I, during this time, and we remained so for years later. We had long conversations about his life, about his hopes, about his worries. He asked me about my kids often. My kids knew Isaiah's voice on the phone when he would call me at home, which he often did. And his mother, really close as well. She was an angel. She was a tough angel. She was raised as the daughter of a sharecropper, granddaughter of a sharecropper in North Carolina. And she read Isaiah the Riot Act, I'll tell you, when she had to. She protected him fiercely. And during the darkest times of her course, she continued to be there, even while she continued to tend for her 10 foster children, as well as her own kids. She was amazing. I did come to know Isaiah very well, but we weren't, you couldn't call us friends exactly. Our worlds were too far apart. We came from different galaxies. But my respect and my affection for him grew and grew. His courage was amazing, his insight, and his generosity. But that's not the whole story. And I want to tell you some other things I learned about Isaiah. Isaiah smoked his first dope at age 5. He owned his first gun when he was 10 years old. And by 12, he committed his first armed robbery. He was on crack at 14. A year before his leukemia diagnosis. Even when he was on chemotherapy, he was in and out of police custody. For months after his bone marrow transplant, he tricked me. He tricked me into giving him extra prescriptions of narcotics. And I know he hoarded them, and I think he probably sold them. 2 of his 5 brothers were in jail, one for murder. And 2 years into his treatment, a 3rd brother was shot dead a gun blast through the front door of their apartment in, I think it was a drug dispute. Isaiah didn't finish high school. He had no idea of what to do for legitimate work. He got and he lost job after job after job for not showing up or for being careless. His world was the street corner, and his horizon seemed to me sometimes only one day away. He didn't see a way out. He absolutely hated it. He hated it. But he didn't see a way out. He told me once that he said to me that his leukemia was a blessing, he said, because at least when he was in the hospital, he couldn't be on the street. And then one night, 18 years after his leukemia was cured, Isaiah died. He was 37 years old. They found him on a street corner. He was breathing, but he was brain dead because he'd had a prolonged convulsion from uncontrolled diabetes, never took his meds, and even more uncontrolled despair. Isaiah tried to phone me the night just before the convulsion. He had my home number, and for years I have kept the slip of paper on which my daughter wrote the message. She wrote, "Isaiah called, please call him back." But I didn't. If I had, I know what he would have told me. He would have said, "Dr. Berwick, hi." He would say, "It's Isaiah. I'm really sick. I can't take it. I don't know what to do." He would have said, "Please help me," because that's what he often said to me. He spent the last 2 years of his life in a vegetative state in a nursing home where I visited him sometimes. At his funeral, his family asked me to speak, and the only thing I could think to talk about was his courage. Medical care is a crowning glory in this state. Nobel Prizes. We have a vibrant biotechnical innovation engine that's working for our economy, gleaming hospitals that train a workforce for the entire world. Isaiah's life, his cure, is testimony to that glory. For Isaiah, we made a miracle. But behind that miracle is another story. It's of the miracle we lacked, the cure out of reach. It's a story of failure. 3 levels of failure, in fact, and they demand our attention, and I'm going to describe them to you. Failure number 1, a failure of quality. I don't want it to go unnoticed that aside from leukemia itself, which was very dangerous, of course, the most dangerous moment in all of Isaiah's care came that one night, not from his disease, but from a medication error. He had a cardiac arrest. It was known, we knew, that he had a serious allergy to a particular antibiotic. It was written right there in his medical record. And yet that night, for reasons I do not know, he was given that antibiotic. He had an anaphylactic reaction, and he almost died. He was resuscitated. But we have a long way to go to make our medical care as safe and as reliable as, say, the airplane that I was on yesterday was. Healthcare improvement, mainstay for my work for 30 years, reliable, safe, patient-centered, efficient healthcare, 30-year quest for me, and we haven't finished it yet. We have a lot more to do. That's lesson 1 from Isaiah's life and care. Miraculous medical care is not the same as high-quality medical care. High-quality care isn't just technically, scientifically audacious or awe-inspiring. It is, according to the Institute of Medicine's famous report, Crossing the Quality Chasm, in 2001, it is equally safe, effective, patient-centered, timely, efficient, and equitable. Excellence is in the details, and we have a long way to go. But beyond that, Isaiah's testimony includes a second lesson as well. There's a second failure. After all, Isaiah did die. And from what? Well, I have to tell you, Isaiah would have been the very first among us to blame himself. Time and again, he shared with me his shame, his sense of shame, his embarrassment at not being able to get his life in order, get together. He got jobs, but he couldn't keep the jobs. He tried to stay clean and sober, but his relapses into addiction were much more powerful than the relapse into leukemia. He wanted to stay on his medicines. He wanted to keep his appointments. I know he did, but his chaotic life, his impulses just kept getting in the way. He would constantly say to me, "I'm sorry, Dr. Berwick, I'm so sorry," as if he owed me an apology, which he, of course, did not. But the fact is that Isaiah needed more than we gave him, more than we all gave him. I fought for the help he needed: mental health counseling, addiction treatment, job training, employment outreach, nutrition, and more. But the battle was constant. It was never won. It wasn't a battle. It was a siege. The same society that could and did recruit and support a breathtaking ballet of consultants and medicines and disciplines and facilities to surround and defeat his leukemia cells had not the wherewithal or the habits to surround the agents of his grievous psychiatric and social and contextual illnesses and even engage them, let alone defeat them. Isaiah had 2 lethal problems, and we cured only one of them. We were one miracle short. My daughter's note said, Isaiah called. No one is at home right now, was the recorded answer. No one is at home right now. In Massachusetts, there are 12,000 inmates in our county houses of corrections, 12,000 in our state prisons. The prisons are bulging, and we're planning to build more. And yet fully half, more than half, of the people we incarcerate in Massachusetts have mental illness or addiction. Many of them, like Isaiah, they have life patterns of failure, they have low self-esteem, they have no sense of control over the streets and the circumstances in which they live. Is anybody home right now? Shall we live with this or shall we change it? I don't for a single minute believe that there was a simple answer for Isaiah's life struggle. What I do know is that the web of compassionate, coordinated services that might have given him a better chance, education, social services, vocational training, effective probation, addiction treatment, housing, psychiatric care, continual outreach to his home, that web, it just wasn't there. We cobbled together what we could, a counseling session here and there, a visiting nurse, but the greatness, the poetry of the team that came to help Isaiah fight the cancer cells in his bone marrow had no analog at all to help him fight the malignancy and the patterns of his life. We have built a miraculous healthcare system. What we do not have is a system for meeting and mastering the determinants of health. In Isaiah's case, the determinants are dramatic. They're largely social, how he lived, what he learned. For us, for everyone, all of you and me, the determinants are somewhat simpler: nutrition, exercise, for example. But for changing what makes us sick or growing what keeps us well, we're vastly underinvested in our nation and in our state. I was thrilled to hear a couple months ago that Worcester is now aiming to try to be the healthiest city in the nation by 2020. Maybe tomorrow's Isaiah would survive there. So those are 2 lessons from Isaiah's life, 2 failures. First, we need to commit relentlessly to improving the quality of care, its reliability, its safety, its efficiency, its patient-centeredness, effectiveness. And the second lesson is we need to expand our investments in supports to chronic illness care, mental health care, substance abuse treatment, and prevention. We have to go out of hospitals and toward health. But I'm not done. As daunting as those 2 first failures are, as lethal as they are for Isaiah, there is a third one. It's larger, it's much harder to see, it's harder to cure, it's harder to describe, but uncured, it is lethal too. It's a failure to look one level deeper and to act on the actual systemic causes of Isaiah's pain and death. What killed him? I'll tell you what I think lies at the root: inequality, injustice, and the ugliest manifestation of injustice, which is poverty. I spent much of my youth in the 1960s. It was a time of upheaval in America. We, young then, had come into relationship with injustice in ways that I really can't account for. I wasn't certainly causing it, but we couldn't escape it. The 2 great battlefields for social justice in that time were the Civil Rights Movement and the Vietnam War. They were soon to be joined happily by the feminist movement as well. In all those cases, vast power, great wealth, were defending the status quo. And those who challenged that status quo were doing it at their own risk. There was a time when community organizing and youth mobilization were maturing, though, and the powers of the status quo were shaken. And in some cases, they were overcome. It was the time of the war on poverty and the explicit fight against hunger in America. We labeled it. The Peace Corps had formed. We had a young president who had famously said, ask not what your country can do for you, ask what you can do for your country. And we didn't think that was a ripoff. We cheered. Unembarrassed, unapologetic, we asserted the presence of injustice. It was named, and we tried to stare it down. And I was not a leader among this, I was more an observer, but we took heart from the courage of others, whose courage vastly exceeded ours. They were on the streets of Selma. They were on the arch of the Edmund Pettus Bridge. They said, and the words were, if you're not part of the solution, then you are part of the problem. And we believe that. So where has it gone? Where today is the direct and the moving language that gives a name to the great unfinished business of social justice, and the call to arms to finish the business? We sang "We Shall Overcome" then, and what's the song now? I spent part of a day a few years ago with Gloria Steinem, the feminist leader. We in IHI were studying social movements. We were trying to understand how they work, and we asked her how does she think about a social movement and the mechanisms of change. I wanted to think that way about healthcare improvement, not just as a project, but as a movement. So Mrs. Steinem, she was very clear. She gave a very concise answer, actually. She gave a speech at our annual meeting, and she said there were 5 basic principles. She had all this worked out. One of the principles, though, caught my ear especially, and here's the principle. She said, you have to name the enemy. That was her counsel. She said, for example, we could not fight date rape until we found its name, date rape. I think I know the name of Isaiah's killer. I think it's poverty. I think poverty remains deeply embedded in this nation and in the state. And in Isaiah's case, it was literally in our backyard. Isaiah died not 1 full mile from where we're standing this morning. It is poverty from unfairness in society, from insufficient investment in helping people who need help. It's poverty from the vestiges and the still unclean pockets of racism in America. And it is poverty from greed. It's poverty from our willingness to agree in silence, or worse, blaming the victims to the atrocities of homelessness and hunger in a nation and in a state that should eradicate both of those. Take a look with me, if you want, briefly at the trajectory we're on in the struggle against poverty in the nation. On a national scale, we're going backwards. In the past 3 decades, the inflation-adjusted income of the top 1% of Americans rose 275%. The bottom 20% rose 18%. You might think that a great and a wealthy nation would embrace as a moral duty the principle that no one should be left out, at least of the basic experience of prosperity, a roof over their head, a meal when you're hungry, or a school that's building on their talents, a job that can give them pride, roads and rail that serve them, a chance to grow up strong. And of all the places in the nation, you might think that Massachusetts, the birthplace of the call for liberty and justice for all, would underwrite the strongest promises for equality. We would assume that all means all. Now, you can't reasonably lay the foundation, the failure of commitment today to social justice as a fundamental principle of the Commonwealth at the feet of the healthcare system. Our need is at its roots not for better healthcare, but for clarified values, for a renaissance, a rebirth of shared public and unapologetic embrace of the values that I believe connect us in a civilized democracy. We need to write in our laws, into our skies, that homelessness and hunger and poverty and unattended illness and unacknowledged despair, like Isaiah's, are simply not acceptable, and that we will end them. But I have to tell you that, in my opinion, healthcare does have a role in that, and it is an unwelcome role. We didn't ask for it, but here we are. And if healthcare doesn't own up to its responsibility in this, I fear that we may not see the new progressivism that is, in my view, the only way out of the inequality that now threatens us. Healthcare is going to have to be a part of the solution to social justice. To see that, I want you to take a look at the shape of our state budget over the past 12 years or so. In constant dollars, Parks and Recreation's budget is down 25%, local aid's down 40%, supports to public higher education are down 30%. The rehabilitation and reentry programs in our criminal justice system are cut to the bone. That does not mark a commitment to the end of poverty. 90,000 people are awaiting affordable housing in this state. 4,000 families are homeless tonight. And yet the Massachusetts State Housing Voucher Program, which is our version of federal Section 8 support, has been cut in 6 years from a peak of $130 million, hardly enough, to less than $60 million today. Here's what that means. That means that Mr. Ronald Gibbs, whom I met 2 weeks ago, is living tonight with his 4 children, aged 2 to 12 years, and one on the way, and his partner, in a single motel room, costing the state $4,000 a month, because there is no voucher for him. A voucher that, by the way, would get him a decent place to live at an average cost of about $1,200 a month. I should tell you, Mr. Gibbs is fully employed. He just can't afford the housing. Only one category in our state's budget during those same 12 years has risen, and therein is the tale I want to tell, and that is healthcare. Our state's expenditure on healthcare has gone up by 59% in 12 years, and everything else is down. Healthcare as a system in our state is taking away the opportunity to achieve justice, equality, and compassion through public and private investment. I want to share with you a calculation presented recently by Dr. David Blumenthal, who's the new president of the Commonwealth Fund. It was done there by his colleague there, David Squires. This is the trajectory of healthcare expenditure, if you've seen this slide, I'm sure often, of the U.S. over the past 30 years compared to other countries. By the way, this is reflected in the state of wealth and income of workers. The American worker, just like the American public policy arena, has constantly seen a shift of income toward healthcare and away from other things they might do with their own resources. Blumenthal and Squire imagined, they said, that the trajectory of healthcare expense in the U.S. over the last 30 years, 1989 to 2010 is their calculation, suppose it had not been the highest in the world. Suppose it was just second highest. Suppose it was Switzerland's. How much money would have been saved in the U.S. if the U.S. had tracked Switzerland's expenditures instead of its own? And the answer is $15.5 trillion. Trillion dollars. They ask, what could we buy with $15.5 trillion? Here are some examples. We could buy a 4-year college education for 175,400,000 students. We could buy enough solar panels to cover the state of South Carolina, which I'm not proposing. And that would generate more power than the entire United States uses. We could have changed the $11.6 trillion national debt into a $3.9 trillion national surplus. And we would have health care equal to Switzerland's, which, according to the United Nations, has the second best life expectancy in the world, where the U.S. ranks 40th. This is about Isaiah. We can regard our failure to help him as an individual matter, just not enough services to help a desperate young man. But we can also see it as a comment on the distribution of resources in our society as a whole to build and to grow the complete communities that we want. including the end of poverty itself. It looks like a dilemma. Can we possibly cure Isaiah's leukemia and also cure the poverty that killed him? It isn't a dilemma at all. Healthcare in our nation costs nearly 50% more per capita than in any other nation on earth, and we have nowhere near the best results on earth. We're great for leukemia, but not for chronic illness care, not for prevention. The second bridge has never been built. We are 23rd in the world in infant mortality. We are 40th in the world in life expectancy, and we are continually reducing our investment in liberty and justice for all, in equality, just at the time when we're experiencing some of the deepest and most toxic forms of inequality that this nation has ever seen, at least since the Great Depression. And this places, unwelcomely, a new and an urgent burden on the shoulders of our healthcare system. It has more than it needs. According to 3 independent studies of waste in healthcare, one of them done specifically in Massachusetts, the level of non-value added activity in healthcare exceeds 30%, and it might be 40%. Healthcare takes far, far more than it actually would require if it focused on the work that matters for people. This is like the civil rights movement. It's like Vietnam. It's like feminism. It's like today's LGBT struggle. It's about the distribution of power and the distribution of money. Our vast medical machinery, which produces miracles and is proud of its achievements, is interwoven with vast economic interests that draw upon 1/6 of the American economy. It isn't easy for that juggernaut to willingly rein in its own growth and its own expansion and to change our course toward health and toward social justice. It's even harder because of the fully justified pride in the miracles that cured one of Isaiah's lethal conditions. But it has to change. This is a time, I think, for the powers in healthcare to look hard at the faces of the Isaiahs of today, to see the suffering, and to know that unless healthcare can relax its grip on the public and private treasury and free up the money for us to engage poverty and justice as the project of our generation, then more Isaiahs are going to die on street corners, and their brothers and their sisters are going to languish in broken prisons, and their brothers and their sisters are going to sleep outside and be hungry, and their children will believe that they cannot learn in school, and that there is no good job in store for them, and that no one is at home right now. Please leave a message. And Mr. Gibbs will not have a house. So 3 lessons from Isaiah's life and from his death. First, we must continue without any compromise at all the initial agenda of my career and improvement, and that is to perfect the delivery of healthcare. Let it so that its quality and its safety become everything they can be and they should be. Nothing I'm saying should compromise that. Second, we have to build a network of supports for individuals, the supports that can help people in journeys through chronic illness, through mental illness, through addiction, and for all of us into prevention. But third, we're going to have to find a way to end healthcare's hammerlock on the money that we need, on the public and private money that we need, to devote ourselves to the end at last of poverty and to its lethal harvest, despair, and with unblinking clarity to the unconditional pursuit of social justice and equality and compassion for all, for all. Thank you very much. I'm told we have time for some dialogue, if you like.
We have plenty of time for question and
Okay,
answer.
great. Please.
There will be microphones traveling up and down. Do you have 1 microphone or 2? Two. Okay, where's the other person with the mic? Oh, there we go, okay.
So they're asking, please use the mic
Yes,
because they want to
please,
record it,
if you
your
would.
question, yeah.
Anyone with a question? Over here.
Someone in the middle?
Is there a way to cut that?
Yeah, I can.
First of all,
Perfect.
it's on. First of all, thank you very much for your remarks.
It's not working. Is it on?
I'll repeat your question. Go ahead.
Is it on now?
No.
Please use it, we're getting it.
Okay.
Oh, okay.
How about that? again, thank you very much. Your exhibit with respect to the difference in healthcare between, if we had taken
Switzerland's path.
Switzerland path, right? Without refuting at all any of the consequences of that, how much of that U.S. spending is in R&D that might have benefited Switzerland and other countries and allowed their expenditures to be less?
The question is, how are we is part of the difference that we're front-ending R&D and other countries are using the benefits of our research and development. If it was another country than Switzerland, I might have said, well, we're onto something, but I don't think so. I mean, there is a small, we are doing a little more research and development here. We have the NIH, we have supports for investigation, but it nowhere near compensates for the enormous gap you're looking at. That gap is generated from problems like oversupply, overuse of procedures and tests, supply-driven demand. We know from brilliant, I think, Nobel-worthy research at Dartmouth for 30 years by Jack Wenberg and Elliot Fisher that, unlike other sectors of the economy, healthcare utilization is driven by supply, not demand. So if you build another catheterization suite, there will be more catheterizations. If you build another intensive care unit, there'll be more ICU days without any evidence whatsoever of a connection between that increasing supply and better outcomes. On the contrary, there's significant evidence that the lower the supply, once you're above a threshold in this country, the higher the quality of care. Fisher has looked at the U.S., for example, by quintiles of expenditure. If you divide the United States into quintiles of expenditure by what are called hospital service areas, HSAs, there are 306 health markets in the country. And these HRRs, hospital referral regions, I'm sorry, that's what they're called. It's 306 HRRs. So if you take them by quintile and look at the highest cost HRR compared to the lowest cost HRR, the highest cost HRRs are spending money at about 300% of the rate of the lowest cost HRRs, and they have the worst outcomes. And the lowest cost HRRs have the best outcomes. So there's just not much evidence of a value-added profile to this level of difference of expenditure.
First of all, thank you very much for your comments. My concern is that cutting back dollars in health care is heavily impacting Medicare and Medicaid, and we're seeing doctors drop out of both of those programs. And could you talk a little bit about that and how we could stem that tide?
Well, so I guess having run Medicare and Medicaid, I'm not exactly an objective observer. First of all, the data belie the trend. There are plenty of doctors staying in Medicare and Medicaid. Medicaid has always had a lower number of participants, but you actually look at access, it's been very good. And those two programs are performing at very high rates of service and reliability from the point of view of the publics they serve. Try to take away Medicare in this country. Just give it a shot. It's not going to happen because no one wants to see it go away. So I think there's a little bit of people that oppose a progressive role for government. They don't believe it's right. They don't believe it's the proper role for government. Are I think emphasizing the wrong data. I think that but beneath that is the lesson. When you look about the possibility of us going to Switzerland levels of care, so, I mean, just we're at 18% of GDP now. Imagine it were 15%. Where would you get the 3% difference, which would be plenty to fund everything I just talked about? I wouldn't do it by taking away value. And so if it proved the case that paying physicians better or nurses better, I think even more importantly, sure, let's do that. If it adds value, let's do it. But the evidence is the non-value added activities are extraordinarily great, and there's no real defense for those. I wrote a paper in JAMA in April of 2012, the Journal of the American Medical Association. I wrote it with my colleague Andy Hackbarth at RAND Corporation, and we analyzed 6 forms of waste, not value-added activity, activity that add no value. Just for your reference, the 6 were these: overtreatment. So there are plenty of things we know in healthcare that they don't do anything. It's not rationing; they just don't help you. Taking an image of a low back pain at 2 days we know it's a terrible thing to do. You're exposed to radiation, and almost all the pain gets better. Giving a person with a viral infection an antibiotic, it makes no sense. Antibiotics don't kill viruses. So there's overtreatment. The secondary is failure of coordination. So Mrs. Jones is in the hospital, not Mrs. Jones, Mrs. Smith. Any Smiths here? Is in the hospital with congestive heart failure. She gets buffed up and is in order, goes home. The records don't go to the local doctor. She gets mixed up about her medicine. She's back in the hospital in 30 days. I can't remember the exact readmission rates, but it was 20% in a month. Well, that's all rework because we didn't do the handoffs properly. I worked in Alaska for a year and a half in the Indian Health Service in the mid-1990s when my wife had a sabbatical there. And the system there is now called NUCA. It's a totally coordinated, home-based, spiritually based system that has reduced hospital use 53% in 5 years. 53% less hospitalization, 65% fewer specialty visits with better outcomes. They do it by being a team. The third is failures of execution, unreliability. So we know how to not give someone a pressure ulcer in a hospital. You can drive it to zero, but they still got pressure ulcers. So whenever there's a failure to use knowledge, that's waste. The fourth category is administrative complexity. Just follow a doctor or nurse around the hospital and watch how much time is being used in paper record keeping, let's say, or go to the hospital, look at their labor distribution. There are banks and banks of people managing paper, moving things around because we made administration complex. My colleague David Cutler at Harvard has done a very thorough analysis showing he thinks that administrative complexity is the #1 form of waste. That doesn't help anybody. The fifth is pricing failures. I can tell this as a Medicare administrator. There's a lot of things we're buying in healthcare that actually are functionally commodities. It just doesn't matter where you get it. And so what we should have is a very active bidding or auction structure where real competition exists for things. We should commoditize commodities, but we don't. We treat them all like they're, Fabergé eggs, and everything's boutique, and the prices are way high, and you can read those data. It's shocking. If you compare Switzerland to the U.S. and look at the pricing, you'll find we have 10-fold higher prices for things that long ago were commoditized in Swiss healthcare. And the last category is fraud. I'm a pediatrician. I'm a nice guy. I don't believe in fraud, but I saw it and I got a little bit angry. There are a tiny minority of people who give care do it dishonestly, and they bill for things they don't do, or they set up mills. Well, when you add up those numbers, in our estimate, in our JAMA paper, the median estimate in the U.S. context, and we true in Massachusetts, is 34%. 34% of the bill is in just those 6 categories of non-value-added activity, and that's not denying doctors fair pay. That's just doing stuff that doesn't help anybody. That's what I would go after, and I think it's there.
If I can preempt and ask my own question, if that's all
Of course.
right. How do we find the way out? We're obviously in a political gridlock, and I know this is a really complicated question, but are there avenues that you see that will actually have a good shot at moving us forward?
Yeah, yes, of course. I think, I'm an optimist. I think the two things there are probably 10 answers to your question. The two that I'm trying to resonate with in my remarks. One is a return to values. We really need to have a moral vocabulary recovered here, because it's at risk. You just listen in the airways for who is speaking up. Or name, maybe a positive way to say it is name the vision. Social justice sounds pretty good to me. Let's recover the moral vocabulary. And I think if we don't have that dialogue, we can't do the second piece. And the second piece to me is mobilization. It is, maybe I just am romantic about my youth. And I wasn't, don't get me wrong, I wasn't a leader in the streets in anti-Vietnam or civil rights, but I was a follower. And there were people in the streets. And there's a time now we're at where I think if we don't start to come to our senses and get the grassroots, the average people to understand that it doesn't help anybody when Mr. Gibbs doesn't have a place to live. It just doesn't, it hurts everybody. It costs money, it insults us morally, and it takes a man who's fully dignified, fully able to participate in society, and removes him from participation in all the good things that he could be doing. So there is something here about voice that I think is quite real.
Don, during your short time at Medicare and Medicaid, what did you get done? And if you had been there a longer period of time, despite the mess in this country,
Yeah.
what did you see that you could possibly get done?
In terms of what I could have done, speculative, I can tell you what I imagine. When I was there, so I came into Washington in this period of growing and worsening gridlock. Authentic conversations about problem solving around the issues that I've shared with you this morning, it really wasn't there. Not authentic conversation. It was in the staff level, but at the visible political level, it's all theater and all grenades and sound bites. And I kind of knew that right from the start. And I must say, with all due respect to this president, who I have enormous respect for, what goes around comes around. So when you start this cycle of sound bites and grenades, it goes both ways. And so the dialogue goes away, and you can't sit down and kind of work it out. And I knew that. But I also knew from 30 years of executive experience running and growing my own organization that I could be an executive. I could, within the agency context, begin to focus on some of the issues I told you about. So what I'm proudest of there is beginning to work on the culture of the agency. There were 5,500 employees, $820 billion budget, 100 million Americans who depended on it. There's a quotation in the hallway of the Hubert Humphrey building. That's the building I would eventually work in, but I saw it when I was interviewing for the job. Humphrey said, "The moral test of government is how it treats people in the dawn of life, children, how it treats people in the twilight of life, the aged, and how it treats people in the shadows of life," he said, "the sick, the needy, and the disabled." That's 100 million Americans, and all I had to do was quote that. I just read that quote to 5,500 people on the third day I was there. We had an all-staff meeting. You could do that virtually, and I just said, that's why we're here. We'll be a major force and a trustworthy partner for the continual improvement of health and health care for all Americans. And I don't care where you work, cafeteria, Medicaid, Medicare, survey and certification, compliance office, we're all in this together. It's 100 million people who depend on us. And I said, as an administrator, my job is simply to get out of your way, to help you do what you want to do. So you talk to me. I visited all the regions, and I began a process of quality improvement there. We trained, by the time I left, we had 200 black belts trained there. That's the industrial version of process improvers. And I reviewed all of their projects. So we were starting a cycle of pride and joy and commitment in the public sector workforce, the civil servants, that I thought was amazing. They were wonderful, just wonderful. And I would have kept that up. I think you can't get great results from a demoralized workforce. And so focusing on the management issues seemed to me to be absolutely crucial. And getting voice for patients. So, it's a canonical principle in modern improvement that when the customer's powerful, things get better. And so the customer for Medicare and Medicaid are people who need care, and the doctors and nurses and others who serve them. So I began a process of bringing them in for dialogue. I gave 4 lectures there over the first few months on quality, and one of the lectures I didn't give, actually, Sorrel King did. Sorrel's the mother of Josie King, who is Josie died. She's an 18-month-old girl who died at Johns Hopkins from a medical error, and I wanted to focus Medicare and Medicaid on patient safety as one of the core themes that I brought there. And I had Mrs. King lecture 5,500 people on the importance of safety and what it meant to lose her daughter. And that culture change was, I thought, had phenomenal potential, as it has in every organization I've ever worked with. And had I stayed, we had worked on it. I'm very focused on reliability and execution. Implementation is absolutely key, and that's done by a buoyant workforce with proper supports and good monitoring and metrics and support. And that would have been my theme. The other thing I worked really hard on there that I'm proud of was interaction among agencies. So I began processes, for example, with NIH. I went to the head of NIH and said, you know before we do what's coming down the pike, so why do we wait to see a new drug or a new test? Let's work together in advance. So we'll do early warning. You'll tell us what's coming down the pike, and we can get readier sooner and not have these delays. And Francis Collins said, that's great, we'll do that. And by the way, you have data that would allow us to learn a lot more faster, so could we work a deal? And we had an NIH CMS connection that was phenomenal. It was amazing what happened. So I was very interested in breaking down barriers between areas, and I would have worked further on that. Siloing doesn't help public or private government. I think public or private enterprise. Had I stayed, I don't know. I mean, it was the luckiest time of my life. I got to participate in the most majestic era in American healthcare since 1965. This country is trying to make healthcare a human right, and despite all of the Sturm and Drang and these irresponsible statements and website up, website down, hold on a minute, people. We're trying to give 32 million people a human right, and I got to be part of that. And had I stayed, I would have loved to continue to be part of that. That's really important. And for you, man, we got to keep the public's vision on that, because we lose sight of the majesty of that enterprise if we get caught in the weeds right now.
Thank you. I'm a social worker at that inpatient medical unit, and we usually have to keep a homeless man in the hospital because there is no bed available at the shelter. We usually have to keep an elder because when he was admitted to the hospital, she or he didn't meet criteria to be hospital level of care, so they don't qualify for rehab. We usually have to keep people with addiction because there is no dual diagnosis program, or we usually have to keep patients because they don't have insurance and they cannot have a follow-up appointment or a test on outpatient basis. My question is, what can we do to help with a change, an effective change?
Well, you're more than halfway there just with your question. I mean, we just have to understand the phenomenology you're talking about, and it's coming to our senses, isn't it? I mean, everything you described is not only bad for human dignity and suffering, it costs more. And this myth that we're in a win-lose cycle here, that if we help people, somebody loses. If we help the safety net, the middle class loses. It's wrong. It's dead wrong. And we need probably, from the point of view of university, we need that constant attention to the analytics that will show that, and real voice. We are cutting the supports that we need to prevent the trouble you're talking about, and we got to stop it. That's what I was trying to talk about here. I think some of that is healthcare costs reallocated, but more is a reestablishment of that voice. It's grassroots. I was at the Suffolk County House of Corrections week before last now with Sheriff Tompkins, who gave me a half day to show me around this place. And it's really interesting, the dedication, the professionalism of the workforce there, the sheriff, the administrator, the corrections officers, was very impressive. Everyone standing up straight, dignified, the way they referred to the inmates with respect, concerned deeply about their primary mission, security, but also about caring and re-entry to society. They're trying hard, but they don't have the resources. The sheriff, they have about, I think, 1,050 people there now. Half of them aren't inmates. They're in pretrial detention. They're people we're taking out of their homes, out of their jobs, and putting them into locked cells because we cannot find a way in this clever, remarkable state to create a support system that would allow these people to stay connected and get reconnected faster while they're being sorted out. And 85% of the people at Suffolk County House of Corrections have some connection to substance abuse. And yet we're cutting substance abuse programs. I was at a homeless shelter in Lowell, in a room this size, full of cots, which are just the overnight cots. Those are the cots that people flood into that facility now at double the rate they did 4 or 5 years ago, just to have a bed at night. And it's all mental illness and substance abuse. And there is not a single respite bed, not one rehab bed in the area served. Instead, we're playing catch up, and that's what we did with Isaiah, and we need to stop it. Yes.
My name is Ann Denoto, and I live in Arlington, and I'm on staff at Boston University in a totally unrelated area, if you will. And because of my own personal story with periods of unemployment and housing struggles and so forth, and changes in stagnated income, all the things you talked about, I've become involved in healthcare for all. And I'm having a meeting tomorrow with some grassroots organizers, if you will, and we're struggling to figure out what we're going to do. It's that, I think I loved your speech. I think all the things you talked about were great, but we're a group of probably less than 10 people, and we're really struggling on what we should do next. So that's my first question. And then the other thing I'm involved with because of personal history is I have a family history of suicide. And so I've become involved in American Foundation for Suicide Prevention. I'm going to the state conference next week. I've gone to DC for advocacy. And so mental health care is also a big concern of mine. So as far as grassroots and advocacy on that level, I'm curious what advice you would give. Thanks.
Thank you. Sorry to hear about the difficulties. You're not alone. Let's start with substance abuse. So my career in improvement has a number of components to it, but a lot of it was studying modern methods of management and leadership that allow organizations to thrive and grow. And so there's a leadership piece. But one of the key ideas is starting with the idea that whatever problem you're facing, probably somebody somewhere has taken a better shot at it than you've been able to think of. They say in Silicon Valley, most of the smartest people in the world are not in this room. No, it's no insult, but so if you just assume most of the smartest people in the world are never in the room you're in, then you become very curious, a searcher. And I think that part of, I'm not saying you can do it, but small groups can do this, can find something better. And I think one of the great roles for a university, by the way, is to be the searcher. And don't hold the knowledge. Make sure you're sharing it. And in this modern world, this modern internet world, there are answers. The one I'll commend to you in the mental health end, I discovered accidentally, and that's shatterproof.org. I'm amazed by it. Gary Mendel is the founder. Gary is a very wealthy man. He owned a bunch of hotels, but he sold them all because his son became addicted to marijuana and killed himself 3 years ago. Brian. So Gary quit, and he formed brianswish.org, now called shatterproof.org, and it is a very ambitious, very well thought out, systemic approach to the serious reduction of substance abuse and suicide, community by community. I want to help him. I am helping him. I want to get that thinking into every community in the state. Yesterday I was in, where was I? South Shore. I was in Hingham. And all they were talking about was the heroin epidemic. Well, let me tell you, it's solvable. It is solvable. We just have to get that done. I think community by community is the other issue. I'm not enough of a social scientist to be sure, but I wouldn't wait for Washington right now. And I mean, someday we can. There'll be a new time. There has to be a new time in this country that we will recover, because we won't tolerate what's going on. But that's going to take a little while. So what about communities? I have a story. I can't. Am I going on too long here? I just can't help telling this story. It's I was in Ipswich for an event related to my current career, and before they had the formal session that they were holding, the Ipswich breakfast, they paused to have a celebration of the playground at the Whittier School, which is an elementary school. And the best speech was one sentence long, given by Finn Hackett. Finn is 10 years old. He's a fourth grader at the Whittier School. So the story is this. The playground was not a good playground. It was not accessible to disabled people. It was dangerous. And they couldn't get the town kind of together to kind of invest in the new playground. So a bunch of parents said, we'll take it, we'll do it. And they organized. And then they started getting donations. They got a world-class architectural firm, I think, to donate a design for the new playground at the Whittier School, and they got the local lumberyard to give them materials and all different artisans. And then they announced that they were going to have a 5-day period in which they would ask some volunteers to show up to help put it all together and build the playground. And Ipswich has 12,000 people. That's the residents. That's the population. 500 people showed up for 5 days to build the playground. They worked so late in the night, the police eventually had to send them home. They thought it was not right for them to be working all night. 500 people showed up and built the playground. Finn Hackett's speech was 1 sentence long, and Finn said, what he said was, if I can get it right, not everybody is as lucky as I am to live in a place where so many people help. And so I'm carrying that around in my head, thinking about Mr. Gibbs in a motel room with his 4 kids. We got to be lucky enough to be in a place where everybody helps. And I don't think that's not going to be Washington right now. I don't even think it's going to be a major state. It's going to be a place by place. It's Ipswich, it's Fall River, it's Dorchester, it's JP, it's where you live. And I think this is maybe a time to return to communities, and your power will lie at a level like that right now. And I think we can do things, start there.
Thank you very much. Jeff Wilkinson, and I work for the State Department of Public Health, but I'm a social worker by training and orientation. Social workers talk about addressing the elephant in the room, the so-called elephant in the room. And amazingly, while there have been oblique references to it, nobody has actually said, and including you, that you're running for governor of the Commonwealth of Massachusetts.
It's a 501c3 here.
Oh, well. But I hope I can ask you, if you were elected governor, how would you use that lever to address with the legislature and with the captains of the healthcare industry the need for redistribution that you've talked about?
Well, I don't want to answer personally. It's not appropriate in the setting about me. But I think I'll just say a bit about leadership right now. What we're seeing nationally is I do think there is there's a striking loss of appeal to the moral vision of the community. I don't mean that somebody articulates the vision and sells it to the community. I think it's what is resident in the communities. So I can tell you, I think people don't want this this way. I don't think they like that you feel so helpless, or that people are left out, and they want to live in a place that's fairer. And I think the problem of the win-lose logic, that somehow it's come to be the belief that social Darwinism actually works, or that people who are poor got that, should work their way out of it, or worse, that if you help them, you're hurting someone else. That's got to be overcome. And I think we just need to call upon leaders who are going to speak that language. And it's not so far away. I mean, you can hear it. Watch what Bill de Blasio is starting to do in New York. I don't know, knock wood. Let's hope that stuff sticks. But it was interesting to watch somebody name the enemy, the right one. So that's all I can say right now. And I think, by the way, the mechanisms of effectiveness are what you learn at the school. It's management. It's proper management. Management is not. Management is the formal, hopefully science-based mechanisms through which groups of people who want to get something done do that better together. And you can't have a vision without management, or without execution is not effective. Execution without vision perpetuates the status quo, and so you need both.
My question is, there's obviously so much faith in the free market system, and as long as medicine is and increasingly becomes a for-profit system, what hope is there that there will be any cost savings, that anybody will rein themselves in? And secondly, I'm discouraged in the sense of not even being able to pass a public option for Obamacare. How how close would we be to being able to at least get a public option, let alone a single payer system?
There's a couple of questions you're asking. I mean, like I said in my talk, there's a power distribution, and it approximately maps to the money, and the money will be in the status quo. So whenever we want a social change, there's a power issue in place. Marshall Gans teaches that. So the study of mobilization, why I went to Gloria Steinem, is absolutely key, and it's not going to be there just for asking. You can't just ask the people who were not just successful in the status quo, actually proud of it, and they should be. They've accomplished a lot, to say, oh, stop that, do this. It's going to have to be a different kind of voice. So I think political activism and mobilization are going to matter a lot. And at some other level, intolerance of greed. I'll tell you a quick story, and I don't know where you were in the social work school if you realize this went on, but here's something I'd live with as Medicare administrator, Medicaid administrator. Premature labor leads to low birth weight, and low birth weight leads to big trouble. So when a woman goes into premature labor, you'd like to be able to help her stop the premature labor and have gestation get longer. And you can do that. And there are ways to do that, but one of the most effective is a drug, 17-hydroxyprogesterone. It's an old drug, decades old. It's simple. And it is very effective at interrupting premature labor. When the FDA was set up, the Food and Drug Administration came into existence. Of course, every drug in the world had not been approved by the FDA, so there had to be a grandfathering process in which drugs were allowed to continue for a while without FDA oversight until someone applied for it to be approved. Well, at that point, there's a loophole. And the loophole is that even a very commonly used drug can suddenly be patented by a company. And if it's an orphan drug that treats fewer than 200 or 250,000 people a year, it can be exclusively patented by that company. That's what happened to 17-hydroxyprogesterone. It was patented by KV Pharmaceuticals. Suddenly, they changed its name. Instead of 17-hydroxyprogesterone, it became called Makina. And the price went from $300 for a total course of treatment to interrupt premature labor to $25,000 in one step. And there was nothing to do about that. As administrator, I worked with the FDA, and we got a special notice out to all of the Medicaid systems in the country that if they wanted to use the compounded pharmacy form of 17-hydroxyprogesterone, we would look the other way. We would let them do it. The FDA agreed, and we agreed. It's a perfectly safe thing to do. KV Pharmaceuticals, of course, went to court to stop it. The happy news is we beat them, but not without a fight. And let me tell you, here's what they did. Half of the premature labors in this country are Medicaid, because half the births are Medicaid, and half are not. They essentially, not quite, but they sort of gave the drug away free to people with commercial insurance, and they charged Medicaid $25,000 per course of treatment, $1 billion out the door. Now that's over. I think that story is over now, but that's no. I mean, that's where you absolutely are going to need a public that's aroused and just not tolerating that behavior. And I guess I'm saying again what I said to you and you. It's an aware and informed public that's going to start to view this as a problem of mobilization is one of the only remedies I can see. We can do smart things in payment. If we change our payment system away from fee-for-service payment, which I would do tomorrow if I could do it, you'd start to see behaviors like that NUCA system in Alaska, which is globally funded, thinks rationally about the use of resources. And I personally think a single-payer system, a Medicare for all system, needs to be tried. I think this state should try it.
I think we have one question here, and depending on time, we may be able to take one more.
Thank you very much for your comments, your inspirational comments. I'm right here. I have been in the healthcare world for about 30 years, and I have the pleasure of working for a PACE program, which is a wraparound model of care for frail elders. And I think the model is phenomenal, and it's probably been the best place I've ever worked. One of the things I'm concerned about is the move towards managed care in these dual initiative programs that states are moving to, because managed care companies by and large have not been known for their social conscience or for offering benefit options that get at some of the issues that you're talking about. So can you help me connect how that
happily
is getting us where we need to go?
Well,
Thank you.
First, PACE. PACE is the program of all-inclusive care for the elderly. Amazing program. When I was administrator, I visited the PACE program. The first one I went to was in Philadelphia. I think there's one in East Boston. It's quite incredible, and it takes elders who are quite severely ill, and by putting them in an integrated and supportive environment oriented a lot toward home and their needs, keeps them functioning at a very high level for a very long time. I remember a guy named George. George, I met him in Philadelphia, an elder. He had been in the hospital. He'd been in the hospital 5 times the prior year, got into PACE, and now it was 0. So it's great. It's another lesson that when care is team-based, integrated, home-based, spiritually oriented, involves things like nutrition and safety, things get better. We know that. PACE is a very expensive program, and it's been troubling to think about how to scale it. And so getting PACE to scale would be a great enterprise for the country. I tried as administrator, but there's going to have to be some redesign to do it. But in the meantime, we started this program for duals. Dual eligibles, that's the term for people who are covered by both Medicare and Medicaid. And I don't have to get into imagine what the state you have to be in to have both Medicare and Medicaid. You have to be poor and sick and have a lot of trouble. So the question now is about managed care, and I don't want to lose you on this, but managed care, small m, small c, is great. You don't want to go to an unmanaged opera, I hope. You know, you want someone to be thinking about how things should be organized. So I saw patients in the managed care system. Look what I got for Isaiah. Now, I didn't do that. The team did it. We had everything under the roof. I was never, ever told not to do something. I was just given all the resources to act like a system and able to cure his leukemia. And I didn't do it. The team did it. We all did it. And that's managing care, and we need that, and we don't have that. It's fragmented. So the idea behind the duals program, I think, is let's get that. Let's get yes, companies, I guess we'd say, organizations are going to have to figure out how to orchestrate. So these very, very people with very great challenges have orchestrated care. But we have to get the payment right and the incentives right, and also, in my opinion, keep it in the public interest sector. You know, I strongly urge us to go toward more managed care, not less, but to do it with forms of accountability and duties to the public that will allow it to be really teamwork instead of just managed money.
I think we're going to take the last question here, and then perhaps Dr. Berwick will stay for a minute or two afterward.
We've just heard that that Medicaid that CMS has released data about physician payments. Could you talk about that, and do you think that will have any influence on kind of care that's provided and how people think about that care?
Yeah, I'm smiling because I was at the front end of that. When I was administrator, I really worked hard to get those data released, and it just happened, just a couple days ago, right? So I've been under the federal ethics rules. I couldn't deal with the agency or with the department for 2 full years after I left, so I didn't even know it was going to happen. So, but I'm really glad. I think my friend Richard Smith, who used to be editor of the British Medical Journal, Richard once said, transparency is the closest thing to a panacea that humankind has ever invented. And I really believe that. We really do need to turn the lights on the flows of resources, on how we're doing, on needs, and I'm totally in favor of that kind of transparency. And I think you see it. There are profiles in that release that are really, really disturbing. They need to be investigated. We need an activated press and a public that's aware and begin to look at, well, how could that possibly be happening? Is it prices? Is it fraud? Is it excellence? Is it that some people are doing really well because they do something really well? But I think I'm all for turning those lights on. I'll say one more thing, which is about the role of the press. I just finished Doris Kearns Goodwin's book, The Bully Pulpit, in which she writes about the other progressive era, 1890 to 1910, when there was concentrated wealth and power, and it wasn't working on behalf of people that needed it, and the barons of that power thought they were doing a good job, not a bad one. But there were sweatshops and child labor practices and concentrated pricing scams and not justice. And then it started to change. And that's the era that first came where we first had the right kind of child labor laws and growing union movement and a sense of, wait a minute, there's something wrong here and we have to fix it. And if I read her book right, that didn't just happen because of progressive political leaders or because of a distressed public. It happened because of an activated press. And so Joseph Ries, the Dutch author of a book that swept the country, The Faces of Poverty, or whatever, what was the name of the book? I can't someone remember, but it was a photographic essay showing the tenements and the sweatshops and child labor, combined with the muckraker journalists who were very disciplined. They got the story right, and they wouldn't give up until they were able to tell the story. And I think there is a role here for telling the story right, which I hope someone picks up, because when the journalists accede to the soundbite world, and everything's in 30 seconds, and it's got to be dramatic, and the subtleties can't be explained, we lose the chance to understand the real dynamics, and then, frankly, I think the status quo does win. So I'll just say that's part of my hope, that we have the stories told. Thank you very much.